they will give you a huge number. So 1994 breakthrough made it possible for us to merge all these, like in Limpopo now, these 4 governments made one Limpopo Department of Health. So in the country, we had one National Department of Health supported by its 9 provinces. So meaning we're not a federal state, we're one country with 9 provinces. Now, what is the challenge that we saw post-94? Pre-94, the divide was based on your language, your culture, your color of the skin. But post-94, now what we begin to see, it has become a class struggle where you are divided based on those that have, that can afford, those that cannot afford. Those that afford in the country, they form 14%. In South Africa, 14% of the population can afford private health care, whereas 86% of the population is dependent on the public health. Now let me narrow it down to the province that we are here to talk about. In Limpopo, we then have estimation of around 5.7 million people. Of those, 91% it's dependent on the state, and only 9% can afford private health care. Now that tells you that whatever budget we have, already it is overburdened by the majority of the citizen. That is where the inequality is. How is South African government responding to these challenges? Because pre-94, it was legislated, it was whatever. Post-94, private healthcare and public healthcare are not legislated. People just come out of the greed of the capitalists, that you would have those with money acquiring private hospitals, building private hospital, which it's over-resourced with a few patients, but have got a lot of staff and a lot of resources. All the first-class equipment, they're there. The public health on the other side, saving 91%. There's a lot of competition with many people with a high burden of disease. We understand that poverty, being in the rural area, the risk of you having quite a number of huge burden of disease, the lower level of education, when you compare with those who are in the private healthcare, they are highly more educated, and chances of them to acquire certain disease are very limited. When you look, for example, if you look at maternal death, the reason why you have more maternal death rates in the poor and where the low socioeconomic communities, or the population that is not educated, it's mainly if one of those risk factors that you see, that even access to antenatal clinics will not be the same as when you are in the private sector. When you're in public, all these long queues, the availability of medicine and all that. So South African government, that is why you might have heard, we're responding with what we call national health insurance, where we are going to have all the pool of all the funds of health to be managed by one insurance. And in that, the providers will purchase that. So those who have, like me, who is a professional and working, I will contribute to the medical insurance through tax. But those who are from a poor background, or when you look at their economic classifications to be low, they will not be contributing like I do. They will be subsidized by what I do. So we are on that stage to try to address these resources that are skewed towards the 9%, instead of them to be skewed towards the 91%. So where we are now, those are the major challenges, because this imbalances in terms of the funding has resulted in, you'll find that the public health care, it's overburdened with the patient, it's under-resourced in terms of equipment, in terms of human resources. So that is why you see private, when you go there, because you are also paying a lot of money there, the attitude of the staff there, because the reality is that if I'm a physician and I'm seeing 200 patients, and somebody there is a physician is seeing 10 patients, my attitude towards 199 patients will never be the same as the one towards the number 9 patient. And also when it comes to the treatment that they will receive, these patients will not be the same. Hence, you will find there is poor quality in the public sector and appear to be a good quality in the private, because they are dealing with small volumes. So we are in the process of addressing some of those challenges that involves the funding.
So this sounds like a problem of underfunding of the health delivery system. So in 2001, African heads of states met in Abuja and they agreed that 15% of every country's national budget should go towards health. How much are you investing towards health as a country in terms of your budget percentage?
I just need to verify what is the latest, because there was trying to be improvement. At some stage we were at 8%, but the problem is it's not how much it's being put on the funding, how much of our GDP do we put on the funding of the health. The more main problem here is that how much of that which is being put, it's going to the public vis-a-vis going to the private. And we have of course seen in the recent past years the disinvestment on the public health, and that's not a problem that is unique to South Africa. Hence, you have seen that even at the United Nations level, the universal healthcare coverage has been resolved, as we heads of state having to look at that. And for that, I must recommend our government, because the commitment and that as it's being looked at, and we believe that the universal healthcare coverage will be achieved through the national health insurance.
So, to what extent your country is surrounded by by many countries? You have Swaziland, you have Lesotho, you have Namibia, you have Mozambique, you have Zimbabwe, you have Botswana. To what extent has the influx of illegal immigrants affected this? Because the issue that has sparked this whole discussion is about illegal immigrants coming into your country and specifically into Limpopo, seeking medical health. And there is now a problem where locals are having to fight with their foreign brothers and sisters for access to medical help. To what extent has this been caused the problem?
I think Hopewell, towards addressing these imbalances that have been created, and while we are struggling to say we need to correct the funding model that has been used since 1994, post democracy, we then found another major challenge, which is facing the very same overburdened public health and under resourced, being our illegal immigrants. And for instance, when one was interacting with the patient, because sometimes you assess the level of literacy of a patient, and then you want to go to that patient and explain some of these things, because you can see this person can be able to understand what you're talking about, so that they don't go out and say, but South Africans are unfair, South Africans are that. Now, one of those explanations was just to simplify that you have got Stats SA or census here, where they will go around counting us and be able to come and tell you that Limpopo, you've got so many population, and presenting those statistics to the National Treasury, which will then look at its fiscus and then allocate budgets based on the data that is available. And our province, it's not same as Gauteng or KZN or Eastern Cape in terms of the citizens. we are lower than them. Then the budget will talk to those legal or people who are in the country documented. Let's use the word documented, and it will give you the understanding to say how many citizens do you have and how many documented citizens you have. Now you are given this particular budget to address that. And then already with the budget that you are given, you are already complaining that this budget, it doesn't meet the demands. Already I've shared with you the broader challenge of funding of healthcare in the country. So on top of it, you are hard hit as the public sector, because the budget that you are then given, it's based on the population that is available. And the undocumented, when they enter the country, they will never be accepted in the private healthcare. That we know it's a fact. Because even South Africans, when I am sick like this, if I go to the private healthcare, even if they are the ones who are now raising the issue that Section 27 talks about access to emergency healthcare, we don't see that in practice in the private sector to say, even if it's a South African citizen involved in an emergency motor vehicle or in labor, you go to that facility, you either must put upfront the money that you have, or secondly, if you have a medical insurance, they must be able to prove that there is authorization. You know, these days there is even pre-authorization before they touch you. So, but then when it comes to the state, we do our things differently. What we want to also put it up front, it's that people must understand, and I think we can all agree, and this is also apply to us South Africans, is that everyone must pay services. There are two categories. You have got a primary healthcare where it's free at the point of entry, which is the primary healthcare, where you go to your clinics, you get immunization for your children, you do your antenatal and even deliveries at the clinics. You get your vaccines. We're not paying at that level. It's free primary healthcare services. It's funded by the state. When you move to the hospital level, which is where people do not really are failing to understand, when you get to the hospital, you must pay, because you are now entering a secondary and a tertiary services. And how does the system work for you to pay? When it's me, Poppy Ramathuba, because I am at a certain economic class, when I arrive there, I go through a means test, and I'm told you are at H3, meaning you are earning above 72,000 per annum, or you've got a medical insurance, then you will cover full payment. Or they will say you are what we call H2, meaning you are earning just above 35,000 but below 72,000. We're going to make you to pay a discounted fee. When you are now below H2, that you are earning below 35,000, you are H1, and then you will also pay a minimum discounted fee. Then, but when you are H0, this is where the problem is. When you are H0, from a primary level up until tertiary services, in academic center up to central and academic hospitals, you don't pay when you are H0, because you should be able to prove that you are unemployed. And how do you prove that you are unemployed? You either bring an affidavit from the police where it will be a sworn one, or you are going to go to, if you are getting a grant, pensioners for the social security, you must prove using a receipt that you earn that amount, and then you will then be able to be assisted without paying. So this means test function properly for all the citizens and for all those who are documented. Now, the challenge becomes when you are not documented. This is where the overburdening of the system comes in. You are not documented. Some of the undocumented foreign nationals do not even bring an identification document, maybe your own ID or passport. They don't even have those documents. Now, we do help assist them, but we are unable to build them or to classify them. This has got its own repercussion, because when the Auditor General audit us and we are to them, we can't collect this revenue. We must prove why this person cannot pay. As it is for now, we are owing, or we are being owed by patients more than 500 million rands, which must be written off. Since my appointment as an MEC, I have already make a requisition of writing off of more than R1 billion of patients owing fees. Now, when you ask a Treasury to write off those debts, they want to see the proof. Was it a pregnant woman? Was it somebody who was a pensioner? Was this person unemployed? So undocumented immigrants do not won't go to the police to get that affidavit, because they're afraid they might be arrested. Now, what they do, they come in and give us false information, some of them. When they give us the false name, we, upon discharge, when we try to collect this debt, or recover the debt, you find that the information they've given us, the address, nothing works, nothing functions. So already as I speak, our National Treasury appointed a team of some service provider to help us with the collecting of this debt. They were sharing with us that only 10% of the 500 million, they do have a potential to can trace. 5% they've already traced. The remaining 9%, which is 450 million, it must be written off. Mind you, the budget that we get, there is a portion that is attached to revenue collection. I've already forfeited that. Because of the challenges we were facing with COVID and that, we receive a budget cut of 3 billion as a province. Now, I'm giving you this financial complication so that we must understand and appreciate that when we come to the province and refuse to pay, and also our neighboring countries refuse to pay, when we appeal to them to say, embassies, please reimburse, these services were consumed by your citizens. Remember, I know of our constitution, it says health is a basic human right. I want to believe that any country must take health as a basic human right. And I think COVID-19 taught the global community that. So if a nation is not able to provide the health care to its citizens, the best they can do is to reimburse those that are doing that particular work on their behalf. Because human beings are human beings. Life is life. When the healthcare workers sees you, they see a patient, they don't see the nationality. That's a fact. It will be only us who are policymakers who are supposed to help the healthcare workers to collect this revenue so that we can continue to render these services. We have recently, I was with a forensic pathologist trying to do an analysis of all the unidentified or unclaimed corpses, just for forensic only, we have already buried as a country 349 unclaimed bodies, unidentified. Because these are the people, I've not included those who died of medical conditions in our hospitals. These are the people who come and give us false information. And when they passed on in our care, we are unable to trace their families and their next of kin. And you'll find that the corpses can stay in our mortuary for more than 6 to 12 months. And from there, they must write to me. For instance, in Chilizini, we just disposed corpses last December, but I'm told now we already have another 44, which the process now, the procedure says, I must go to the municipality and 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 buy the graves, go and buy the coffins, and come and bury. This is not the money that when Treasury allocates, we'll look into that. So it has put a strain even on our forensic services, such that you will see that even the post-mortem turnaround time has become even slow. The mortuary, at some stage, you might have read headlines to say mortuaries are overflowing. There was a case wherein a patient died around 12 midnight. The procedure now, because we no longer have those, our mortuaries are full by the unidentified bodies. Then what happened is when you die, we must call your family, if you are a local, to bring an undertaker at 12 midnight to come and collect your corpse to go and put in the private undertaker. Now, when the person died at 2, and we know that's the time where most of the people died at midnight. That was my experience. Most of the children are born at night and towards the early hours. So life and death, it's around midnight towards the early hours. Now, our nurses get traumatized by having to leave that corpse until morning when the family comes to claim. And this is a corpse. That's a story at Philadelphia Hospital. The corpse had to sleep with other fellow patients. Now that is the unhumane part of it, where we are being subjected by this current system to say, when the staff leave a corpse that has been wrapped to wait for the family to come because there's no any other place to go. What about the emotional challenges that will face the fellow patients who are alive, and they must be sitting to say, it can be me? They then begin to lose confidence and stress develop, and even the treatment will not work on them. So that is why we're saying, if we can get cooperation from our neighboring countries, and you rightfully put it, Hopewell, to say people might think we are attacking Zimbabwean national. And I need to clarify this from upfront. As Limpopo, you have said, we can't change the fact that we share the geographic location and our border post with Zimbabwe. As such, that is why when you talk about illegal immigrant, every second patient would be coming from Zimbabwe, because we are their nearest. For them, if they need health care, if a woman is pregnant and she wants to deliver her baby safely, she will have to cross the border to come to the province, and which will be Limpopo. And that's why you hear Musina Hospital. It's one of those hospitals that is really hard hit, followed by your Chilizini, your Silom. These are some of the hospitals on N1, your Louis Trichardt Hospital, your Butlokwa, on your N1, because sometimes when they are making their way to Gauteng and other Cape, other provinces, they might fall sick and they will have to be assisted there. So all we would want to raise here is that the challenges that is being felt by the system, it had its own challenges that it was trying to address. But these challenges are not the results of us trying to turn around the system are not becoming visible because we have to carry the burden of undocumented foreign nationals, which their states do not really want to come on board and assist us. So if you go to another province like Mpumalanga, it will be a different story. They will not be talking about Zimbabwean nationals. Perhaps you'll hear the other nations complaining that Mpumalanga is attacking us. If you go to Free State, they'll be talking about Lesotho. They will think they're attacking us. So what we're simply saying is that South African healthcare system cannot, and it will become impossible for it to carry the entire continent in terms of the healthcare system, or even SADC, because we also equally have the Pakistan nationals. We also have the Somalian nationals. They're there, and they're undocumented. We are having to deal with them, providing healthcare for them. If they can't pay as individuals, their state, I still strongly believe, should be able to meet us halfway.
Now, Dr. Ramathuba, you spoke about in the latest video, you spoke about how you're going to send a bill to President Mnangagwa's government. Is this something that you were saying out of frustration, or is something that is on the cards that you actually want to do?
Am I audible?
Yes, you are audible.
Okay. What, you see what I was saying there, and this is one of those clips that people take, you know, and they will be going all over to take some even old clips and circulate. What I need to indicate here was to say, our former Minister of Health, Dr. Aaron Motsoaledi, probably that's why you see him very passionately working around the clock to try to deal with this whole issue of the border post management. Because at that time, I remember when I invited him to come to Musina, what he saw there, it was shocking for him. And we started the process of him leading us, getting countries, governments to come on board and settle some of the bills. I remember the former MEC of Gauteng, Dr. Ramathuba. She was also our deputy minister. There was a time wherein they've also sent some of these bills to the embassies or different governments to pay. We have not received that joy of getting the support. So this cry, it's not necessarily an attack on the Zimbabweans, but it's simple to say how I wish a state or government can come on board and be able to assist in trying to make sure that their citizens are also catered for. If we can't cater on the other side, and we think South Africa should assist, we should formalize it, and South Africa must be able to send the bill, and then Zimbabwe or Mozambique or any country must be able to pay and say, we appreciate that the fact that you looked after our citizens in terms of your ministers cannot afford. Here, we are going to pay. So this is what we are saying. We are not going to stop on this. While at a provincial level, I do not have probably the powers to can reinforce. But what I like about this whole thing, it doesn't matter at what corner you are. You might be at a corner of seeing Dr. Ramathuba as a monster. You might be at a corner where you see Dr. Ramathuba as a messiah. You might at a corner where you see Dr. Ramathuba as unreasonable. But the reality of the matter is that for the first time, we've been able to come and see this matter receiving attention at the highest offices, because all along we will talk in boardrooms, but things would not necessarily be happening. So we really appreciate this frankness and openness. For me, I believe the time had to come where we stop, and it's now. We must stop sugarcoating things and start dealing with issues. We are talking about lives of innocent people, whether they are Zimbabwean nationals or South Africans. But these are lives. And I have got a constitutional obligations and responsibility to make sure that South African citizens, the Limpopo ones, are provided with healthcare. And unfortunately, when the buck stops with me, when a patient dies because they were waiting for an operation, when a woman is being progressed, sitting on the chair because there's no bed in maternity ward, that becomes a litigation on me. Our Human Rights Commission is always on my office to complain about this patient was not treated fairly. But when you raise all these other things that are challenges, to say, can you help us to deal with this? We don't see people coming on board to help us to deal with this, but we see people being very harsh in judging us. When the medical legal negligence, the contingency liability bill is at 14.7 billion in this province. If I'm to pay the entire bill, I'll close shop. There won't be any department to run. When it's up there, the blame is on that nurse, it's on that doctor, it's on that x-ray, it's on that infrastructure, it's on the Department of Health, it's on the MEC for Health. No one wants to look at all these other factors to say, if the norm says an ICU nurse must be allocated one patient, and then we then allocate 4 or 3 patients to one ICU nurse without even proper resources. Because why I'm saying this is putting a strain on us, we are attending to patients that we are not funded for them. Therefore, one nurse is subjected to look at much more patients. Then mistakes will happen, because mistakes will happen for those who are working under pressure, being under resource for long hours. So we are saying we want to see the government playing their part and assisting us in be able to pay for their own citizens.
So you have spoken about the issue of foreigners. They may be Zimbabwean or Mozambican, and indeed you mentioned Pakistani and Somalians. So there's a problem of immigration. People come in maybe illegally, and there's a problem that they access the hospital and they are not budgeted for. And there's a possibility that they may die in that hospital, and you still need to pick that bill. That to me shows a crisis taking place. But what is the ANC done, and what has the government of South Africa done to deal with the root cause of this problem? Because we all know that if health systems were working in all these countries, there will be no need for someone to come to Dr. Ramathuba's hospital. We will all be coming to South Africa as tourists going to Cape Town and Durban, and not overloading these hospitals. If you engage the government of Zimbabwe, for instance, and what have they said?
I wish one day, as Africans, I will be driving like I used to do when I was young. When we were kids, we'll go to visit Victoria Falls through school trips, and the people of Zimbabwe will come and visit Kruger National Park, Mapungubwe, and we share that, and we live as one happy family in the continent. And this the failure of our governments, and I'm no, I'll be in trouble for saying this. The failure of our governments to deal with the border management post, to deal with the whole crisis that faces immigration, has resulted in, unfortunately, is the working class that are fighting each other now. I must say, it is not me who is now on Twitter tweeting about how I feel. It is that poor rural women from Hachikunda Malema who want to deliver in a facility and found that it's full. And when she looks, she would say the people in the room are speaking a different language, and they start to develop attitude towards our own African brothers and sisters, because this is what we are creating as the leadership. We are creating a situation wherein we are comfortable in our own a situation. When we need healthcare, we will go to Morningside and we'll go to Park Lane. But here are the people who do not have any other option. They must fight. Already in the beginning, I said 91% are dependent on this public. Now, even the other ones who come from the undocumented, they come and overcrowd the very same system. So we who created this must do something. I want to believe that, the approach that Minister Mtswaledi came up with. Hence, I kept in one of the debates at our assembly, provincial legislature, because people think we are only raising these things now. We've been raising these things at proper forum. At the legislature, I once raised this, and indicate we need to be seen to be supporting the work that the Home Affairs currently is doing and is embarking on. Because if we do that, we will be able to harmonize. But also, it doesn't end there. Government, we must be responsible when we are leading the people. And we have got to do everything we can to resolve some of the minor issues that you hear. When you see some of the doctors, colleagues will send me messages, both the doctors who are currently working in Zimbabwe and some who are working in the country, to say, do you even have an understanding what we are going through that side? That some of us do not have gloves. Our maternity, it's in shambles. So do not be surprised why this is happening. Now, the people of Zimbabwe should also work with their government to deal with these problems and resolve these problems. Because if, as the nations, as citizens, we do not take interest and say we have an alternative, when I'm sick, I'll cross the border and go to South Africa, they will help me. South Africa also's health system will crumble and collapse, and we won't have anywhere to go. So we as Africans, I strongly believe we can work on fixing the problem. So at the level of the Minister of Health,